Unanimous consent for 5 days to revise and extend my remarks and any others.
Without objection, gentleman is allowed to extend.
And by that, Mr. Chairman Sessions of the Rules Committee asked that his comments he could not be or not be is unanimous consent to submit those to the record as well.
Without objection, he's recognized.
Thank you. All right. As we get started now, we've got a lot of speakers. This is something that has been on my heart for a while, and I know that it is something we have been getting more and more comments and questions about, especially when you're dealing with the pharmaceutical prices, the pharma industry. But when they began to look into it, they began to see that there was actually a bigger issue. And it was not just big pharmacy and the problems that we do see in drug pricing. It was actually the end delivery that's going to actually the pharmacies and how the independent community pharmacists are being beaten down in a way that is really unseemly in our society. And taking that healthcare line tonight. So I've got a lot of speakers. I've got a lot of stuff that I'm going to be talking about. Just as an important reminder, community pharmacist is an important niche in our healthcare system, serving as a primary healthcare provider for over 62 million people, especially in our rural and urban and suburban areas. This is a vital lifeline. Roughly 40% of the prescriptions nationwide and higher percentage of rural Georgia, especially northeast Georgia, are filled by our friends in the independent community pharmacy system. Look, the problems that we have, or we're going to be discussing even further tonight. We're going to delve into some issues that we want to see taken care of. We want to see this industry, especially in dealing with pharmacy benefit managers, put into proper perspective so that we can actually take care of our constituents. A gentleman who has been a fighter and a leader with me on this from day one, since I've been in Congress and dealing with this issue, especially with transparency, is my friend Dave Loebsack from Iowa, and that is a fight that we're going to continue to keep fighting. I know he is as well, and we've got a lot of friends tonight to help us out, and we're going to have continuing on. And with that, I want to yield to him as he continues to tell the story that we've been trying to tell here for a long time.
Well, thank you, Mr. Collins. I really appreciate your friendship. I really appreciate your leadership on these issues. There's really no one in this body, maybe with the exception of Buddy Carter himself, who can tell the story of community pharmacists the way Doug Collins does, Mr. Collins does. And thank you for putting this together. You've been such a strong leader on pharmacy issues. You've been a great partner on the legislation that we'll be discussing this evening. And I'm proud to say that this is a bipartisan issue. One of the few in this Congress at this point, one of the few in Washington, D.C. at this point. And we've been able to find a consensus on this, at least with respect to one bill, and I think we're probably going to be able to do it with respect to others as well. We know for a fact that pharmacists across the country serve as the first line of healthcare services for so many patients around this country. People count on pharmacists' training and expertise to stay healthy and to stay informed, and most importantly, to stay out of urgent care centers and out of hospitals. That's why I'm proud to stand here today with my colleagues to recognize the quality and the affordable and the personal care that pharmacists provide every day. And within that group of pharmacists, we got a subset of pharmacists, and that's the community pharmacists and their pharmacies. They're also a great source not only of the expertise they provide, but economic growth in rural communities like those in my district and across the state of Iowa. And as Mr. Collins mentioned, rural areas are very, very important in this as well. I'm a member of the Small Business Caucus. I recognize how challenging it can be for some of these small pharmacists to compete with the bigger companies. I appreciate their hard work to serve our communities. And like most small business owners, community pharmacists, they have to face challenges to compete and negotiate on a day-to-day basis with large entities as far as their business transactions are concerned. I frequently visit community pharmacists, and I see the great job they're doing. And one pressing challenge facing many of our community pharmacists, in particular that will be discussed tonight, is the ambiguity and the uncertainty surrounding the reimbursement of generic drugs. Generic prescription drugs account for the majority of drugs dispensed by pharmacists, making transparency and reimbursement absolutely critical to the financial health of these small pharmacies. But we know that pharmacists are reimbursed for generic drugs through what's called maximum allowable cost, or MAC. And this is a price list that outlines the upper limit or the maximum amount that an insurance plan will pay for a generic drug. These lists are created by pharmacy benefit managers, as Mr. Collins mentions, PBMs. This is the drug middleman. But the problem, there are a lot of problems, but one of the problems is that the methodology used to create these lists are not disclosed. There's no transparency. Further, they're not updated on a regular basis either, resulting often in pharmacists being reimbursed below what it costs them to acquire the drugs themselves. It's a major problem because when PBMs aren't keeping the cost of generic drugs consistent, those price differentials can be a serious financial burden for local pharmacies. And we know when they have a financial burden, that will affect their business, that will affect the economy in the area, that's going to affect their patients as well. And that we can't have, folks, as we're moving forward, especially in this country, doing what we can to reform health care. And when we talk about reimbursement uncertainty for pharmacies, we're talking about uncertainty for those patients, as I just said. So, look, when we deal with this issue, I think we have to be very transparent about it. We're going to be introducing later this week on a bipartisan basis this Prescription Drug Transparency Act. Specifically, what this act will do, it will increase transparency of generic drug payments in Medicare Part D and Medicare Advantage, the Federal Employees Health Benefits Program, and TRICARE pharmacy programs by requiring that PBMs do three things. And Mr. Collins will flesh this out, and I think Mr. Carter will as well. First, provide pricing updates at least once every 7 days. Second, disclose the sources used to update maximum allowable cost or MAC prices. And three, notify pharmacies of any changes in individual drug prices before these prices can be used as a basis of reimbursement. This is common sense bipartisan legislation. We're going to hear more about that in just a couple of minutes. But I'm very thankful to be here to talk about these issues. And there is one more I want to talk about, if I might, Mr. Collins, and that's the importance of access to local pharmacies and Medicaid beneficiaries in particular. We know that Medicaid beneficiaries depend on their pharmacies as a provider of convenient, trusted care in their communities. And in addition to dispensing vital prescription drugs, pharmacists provide additional services to Medicaid enrollees, including immunizations, Medicaid therapy management, a really big issue, and point-of-care testing like flu or strep tests. These are preventive and maintenance care services that help to fill in the gaps where provider shortages exist. I know we're looking at, reform, maybe replace the Affordable Care Act, but we have to be very careful too. We all recognize the importance of Medicaid, I think, going forward, and it's really important, certainly, for these pharmacies and these community pharmacists and for their patients as well. So thank you, Mr. Collins. I really appreciate your including me in this process. This is bipartisan. It is important to so many communities, so many patients around America, and I'm just happy to be here to say a few words. Thank you so much, and I'll yield back to you,
Well, we
Mr.
appreciate
Collins.
you being here, and I know there's others from across the aisle that are joining us in this fight, and we're looking forward to the continuing. Just going to highlight a few things we go through, and we're going to move through some of our speakers, and we'll spend some time, but I want to highlight something that pharmacy benefit managers, PBMs, for those watching, Mr. Speaker, may not know about, and that's, they don't want you to know about, and it's called spread pricing. Really what happens there is PBMs have the maximum allowable cost, which is what Mr. Lobsack was just talking about, that determine the maximum amount of pharmacy we reimburse for certain generic drugs. However, the PBM's reimbursement price determinations are hidden. There's no transparency in the process. That's the bill that we're going to be putting out. PBMs commonly manipulate the pricing by something called spread pricing. PBMs charge employers a higher price for drugs than necessary and reimburse pharmacies at the MAC, or the maximum allowable cost, which is typically lower. Spread pricing allows PBMs to skim money from the difference between the high rate they charge per prescription and the low rate they reimburse pharmacies. Spread pricing is artificially raising the acquisition cost of pharmacy drugs by overcharging at the expense of retail pharmacies, consumers, and health plans. And that's probably one of the better things they do. This gets worse. We're going to continue to talk about it tonight. I look forward to hearing some more from my friend. Take Mr. Brian Babin. Welcome to the show.
Thank you, Mr. Speaker, and thank you, Congressman Doug Collins, for leading this very special order on a topic that is very near and dear to my heart, the invaluable role of community pharmacists in our society. As a rural dentist, who practiced for 35 years, I can relate to the plight of community pharmacists who must overcome all of the challenges involved in running a small business while serving their patients and serving their customers and doing their job as a medical professional. And just like my small hometown of Woodville, Texas, where I practice, many of the areas in which community pharmacies are located are rural and have underserved, low-income, and elderly populations. This can present unique challenges and oftentimes results in community pharmacists performing a lot of services, such as face-to-face counseling and planning services for patients' medication regimen at no charge, care that is uncompensated by Medicare and not typically reimbursed by private insurance companies as well. And what is even more challenging is the uphill battle that community pharmacists continually face in just getting adequate payment for the life-saving medications that they dispense on a daily basis and still be able to earn a small profit. Community pharmacists rely on pharmacy benefit managers, or PBMs, who negotiate directly with payors, including private insurance companies, as well as Medicare Part D and other government plans for reimbursement levels for medications. The problem is the payment levels that make it up to the community pharmacists after the PBMs have skimmed off the top are well below the pharmacist's acquisition costs and fail to be delivered in timely manners, in a timely manner in many circumstances, in many instances. Simply put, there is a dire need for more transparency throughout this process and for more accountability for PBMs. And I proudly co-sponsored legislation that would do just this last year. It was called the MAC Transparency Act, and I now proudly support this bill again in this Congress in the 115th. Now is the time to act on this bill. And as a dentist, it was my goal to treat each patient to the highest standard of care, a goal that I share with all of the community pharmacists that I know. Sadly, if there is no change in the conditions that community pharmacists are facing, many of these providers will have to close their doors. Many already have, and our patients suffer. For the sake of many rural communities that I serve, I hope to see the MAC Transparency Act and other similar pieces of legislation move forward, as well as a greater spotlight put on the actions of the PBMs so that community pharmacists can get the relief that they so desperately need to continue practicing. Thank you, Congressman Collins, for your leadership on this issue, and I yield back.
Thank you, sir. I think you're hitting on something, and Mr. Speaker, I think this is really something we need to discuss, is we're not discussing simply a business model that was designed in a vacuum that was designed to help. Early on, I've stated this, and I state it every time we have this. PBMs in their first iteration, as they first came about, were a good mechanism to provide pricing and between the pharmacies and the wholesalers. The problem was when they became vertically integrated, when they started owning distribution chains, when they started owning the actual end result pharmacies. When they started doing this, it became then they're negotiating for themselves, and this is where the end user, at the end of the day, the person who pays is the federal government, but also the customer, our constituents. This is what happens here, and we're losing community and independent pharmacists every day. This is just not right. When three companies control 80% of the market and they use tactics like gag orders and other things where they don't want their pharmacist to talk about it, where they send out letters saying that the pharmacist is not on their plan anymore when clearly the pharmacist is, but then refuse to send a retraction letter. This is just, I've said this and I've had people call me after we've talked about this, Mr. Speaker, where they basically said, it's amazing this is happening. And all I say is it's true and it's never really been refuted. So as we look at that, look forward to it. My friend now, Congressman Duncan. Look forward to welcoming you here to the floor to talk more about this important issue for our communities.
Well, I thank the gentleman from Georgia for yielding, and I want to say that in a short time in the Congress, he has become one of our greatest members, and I appreciate him leading this effort tonight. You know, it's sad, it's unfortunate that with any big government program, a small number of individuals or companies find ways to manipulate the system and become wealthy. That's why 6 or 7 of the 10 wealthiest counties in the U.S. are suburban counties to Washington, D.C., and that's wrong. I've read for years about the revolving door at the Pentagon, about the defense contractors hiring all the retired admirals and generals. The same thing has happened with the Food and Drug Administration. The big drug giants have hired all the former top people at the FDA, and we have a drug price crisis in this country today, and there are many parts of it. But we want to talk tonight about one that most people don't know about, and you almost have to be a pharmacist to really understand what is going on. But I rise tonight, Mr. Speaker, to join my colleagues in exposing, as I say, an almost unknown culprit in our nation's drug price crisis: pharmacy benefits managers, also known as PBMs. PBMs are essentially middlemen between pharmacies and drug manufacturers, but the legal relationships among PBMs, pharmacies, and drug and insurance companies have become increasingly entangled and complex. For instance, one of the largest pharmacy chains also operates its own PBM, and one of the largest medical insurance companies also operates its own PBM. PBMs are supposed to be helping keep down the costs of drugs by negotiating discounts and helping pharmacies with managing drug plans, as they often claim to do. Despite these PBM promises, though, I have heard from several pharmacy owners in my district who say that many PBMs are in reality ripping them off by drastically raising drug costs. PBMs have tricks of the trade that include retroactively charging pharmacies more for drugs that they've already sold and processed. I'm also told that PBMs also take too long to update the market value of the drugs on their covered drug lists. But these tricks are just two. PBMs use many more. According to one expert and pharmacy owner in my district, he has seen three primary causes for recent increases in prescription drugs. One, FDA involvement, including requiring modern clinical trials of old drugs that have worked for decades. Two, drug manufacturers needlessly hiking the price of generic drugs. And three, PBMs charging ridiculous prices for drugs and pocketing the profits. According to my constituents, PBMs are the main culprit of the three. This pharmacist recently met with me and shared an eye-opening example. One of his senior customers came in with a prescription for a fairly common drug. The prescription had a real or actual cost of $23.40, but the pharmacist found that the PBM was charging a copay of $250, over 10 times the actual cost of the drug. The pharmacist chose to just absorb the PBM's ridiculous copay and only charged his customer the actual cost of the drug. Another pharmacist in my district emailed me describing how PBM practices are accelerating seniors into the Medicare Part D coverage gap, or donut hole. He said all of these PBMs have these types of unfair compensations. This is not our seniors. Even more pharmacists in my district have also reached out to me saying that they only get pennies on the dollar for the drugs they sell. PBM actions are forcing pharmacies to deny patients access to critical medications or to give drugs away for free. The Daily Times in Blount County in my district recently ran a story on PBMs called Sworn to Secrecy. The article cites a pharmacist in Pennsylvania, Eric Pusey, who says that his patients' copays for drugs are often higher than the out-of-pocket costs. Why? Because of PBM clawbacks. Mr. Pusey says that if he explains clawbacks to his customers, some get fired up and don't even believe what we're telling them. Another pharmacist in Houston says we look at it as theft, another way for the PBMs to steal. Most people don't understand. If their copay is high, then they care. Susan Hayes, a pharmacist in Illinois, says that these PBM clawbacks are like crack cocaine. The PBMs just can't get enough. Some PBMs are facing lawsuits with accusations such as defrauding patients, racketeering, breach of contract, and violating insurance laws. Since 1987, when the first of the three largest PBMs incorporated, drug prices have increased 1,100%, Mr. Speaker, and per capita expenditures have jumped by 756%. The three largest PBMs make up about 80% of the drug market, which includes about 180 million patients. These PBMs often conduct business through mail order practices. They sometimes will automatically fill prescriptions month after month, even if the patient no longer needs the medication, resulting in terrible waste. Patients include veterans and Medicare beneficiaries, endangering them, wasting their benefits and taxpayer dollars, and driving up the cost of drugs. As we heard President Trump say in his address last night, we need to look into the artificially high drug prices right away. A good place to start is PBMs. Mr. Speaker, PBMs must be more transparent in their operations so that they can be held to their promises and to the law. I'll just close by saying that PBMs must no longer be able to get away with conducting their business with such unethical methods that they're using now. In short, PBMs must be held accountable for their roles in the nation's drug price crisis. I join in supporting our community pharmacists, and I yield back to my friend, the gentleman from Georgia.
For my friend from Tennessee, you couldn't have laid it out any better. I mean, that's exactly what we're talking about. And if every member of our body would go home and just go to their community pharmacy and go there, they would hear this all over the country. This is not new. And what has been, I've been on this floor now for almost 2.5 years talking about this, and I've not had the PBMs come and say, well, no, that's not really true, because they do it. So thank you for being a part, lending your voice in your community to that fight.
Thank you very much.
We're also very blessed in this body to also have someone who doesn't have to have come to it like I did and having to deal with it from a family's perspective or from my community. We have someone who has actually done this for a living. And he is my friend from South Georgia. He is a pharmacist. He has made his life. And if his Saul was up at his alma mater the other day and Miss President Kathy Cox, I'd have to say he is a young Harris man as he comes. But the gentleman from Southeast Georgia, Buddy Carter.
Well, I want to, first of all, Mr. Speaker, I want to thank Representative Collins for holding this tonight and organizing this, and also for his advocacy and for what he has done to bring about attention to this very important subject. This, of course, is something that's very dear to my heart. As the only pharmacist currently serving in Congress, I take this very seriously. I take that responsibility very seriously. But it's more than that, because you see, in my professional life, for over 30 years, I had the honor of practicing pharmacy. And I built up relationships over that time, relationship with families, with patients. And when I see what is happening, when I see what is happening in pharmacy now, it's an affront. It's an affront to me. It should be an affront to all Americans. My heart is in this, truly in this. In over 30 years of practice, I've built up a relationship with patients, with families. I've served grandparents, I've served parents, I've served children, and total families. And you can only imagine the hurt that it brings whenever I see these people suffering because of what's been mentioned here tonight. Right now in our country, prescription drug prices are something that's in the forefront, in the news. And there's a problem, a real big problem. And that problem, yes, the pharmaceutical manufacturers, they have a concern here and they have a responsibility. But there's a bigger problem. It's what I refer to as the man behind the curtain. I wrote an op-ed about this and talked about the man behind the curtain. That's the PBMs, the pharmacy benefit managers. And I'm going to call them out tonight. But before I start this, before I do that, I want to just say something about community pharmacists, because they play such an important and vital role in our communities. And they directly interface and build relationships with neighbors and friends. I've been there. I've done that. I understand how important it is. Representative Collins has spoke about it. Representative Losbach, a friend of pharmacy and who has spoken so many times, he spoke about it as well. Representative Babin, Representative Duncan. All of them understand how important the community pharmacies are, how important they are to the healthcare system. But beneficiaries are facing increased costs for prescription drugs without much of a basis or notification on why these costs are skyrocketing. So very quickly, I want to talk about why these costs are skyrocketing. Yes, as I said earlier, some of the pharmaceutical manufacturers need to be held accountable. They do. And I say that, but I also say that I'm a big fan of the pharmaceutical manufacturers. You see, in my over 30 years of practice in pharmacy, I've seen nothing short of miracles. I can remember when I started practicing in 1980. I can remember that people would come in to get an antibiotic and that we'd have to dispense 40 capsules and have them take 4 a day for 10 days. Now I can give them 1 capsule and they can take it and be done with it. People who were going into the hospital back then to be treated for infections, now we can treat them. The advances that we've seen are phenomenal. We talk about the price of some of these drugs, and For instance, the drug that's used for hepatitis C. Yes, it is too expensive, and that price has come down significantly. And it's only as good as it's affordable. If it's not accessible, if it's not affordable, then it's no good. But stop for just 1 minute and think about it. We cured a deadly disease through research and development. The pharmaceutical manufacturers putting some of their profits back into research and development, which I applaud. We cured a deadly disease, hepatitis C, that was killing people. Again, that price needs to come down so that it's more accessible to people. But again, we cured it. So I'm going to cut the pharmaceutical manufacturers a little bit of leeway there. I think it's interesting that the president, in his first month in office, called the pharmaceutical manufacturers to the White House. And he told them, you got to do something about these escalating drug prices. He also talked about those people who are on the other side of R&D, who are on the other side of research and development. He put a notice out and he said, you better beware because we're going to be watching you. The next day, the stocks of two of the major pharmacy benefit managers went down significantly, almost 2%, because they knew what was coming, and they know what's coming now. And I can tell you, as we talk about PBMs, that PBMs, first of all, let's talk about the profits of the PBMs. In a quick history, PBMs came about kind of in the mid-'60s, and all they were was a processor. All they did was to keep up with their goal and their charge was just to keep up and to process insurance claims as insurance came about and became more popular to pay for medications. That's all they did. But over time, they've evolved into more than that. And if you look at what has happened over the past decade, the profits of the three major PBMs, and Representative Collins alluded to this earlier, you got three companies who control almost 80% of the market. Folks, that's not good. That's not competition, and that's what we have to have in healthcare in order to decrease healthcare costs is competition. When you have three companies that account for almost 80% of the market, that is never good. But if you look at those three companies and you look at their profits over the last decade, you'll see that they've increased some 600%, billions of dollars. Now, you can make the argument, well, the pharmaceutical manufacturers, their profits have increased too. Yes, they have, and yes, they should be accountable for that. However, at least they are bringing value to the system by investing into research and development. PBMs bring no value to the healthcare system at all. They put no money into research and development. All they do is to skim it off the top. As medications go up in price, they make more. Representative Collins alluded to spread pricing, and that's exactly what he's talking about, and that's exactly how they're making their money. The more expensive a drug, the more money the PBM's going to make. That's all there is to it. You know, I served on the Oversight Committee, on the Oversight and Government Reform Committee for the past session in the 114th Congress. We had a problem with Mylan Pharmaceuticals and a drug that they had, EpiPen, went up to $600. Unbelievable. Here was a drug that is a life-saving drug that people have to have for anaphylactic shock, that we require, that we in Congress actually passed legislation to require certain for that drug to be on hand in gyms and in schools in case there was a problem, and yet they went up to $600. It was really interesting because during the time that we were asking questions of the CEO, she mentioned, well, when it leaves us, it's this price right here. I'm just going to use round figures. It's $150. And by the time it gets to the pharmacist and by the time it's dispensed to the patient, it's $600. And I asked her, I said, what's that difference there? Where's that coming from? I don't know. I don't know either. Now, there's the beginning and the end. The beginning is the pharmaceutical manufacturer. She doesn't know. The end is me, the dispensing pharmacist, and I don't know. That's what I'm referring to when I talk about the man behind the curtain. That's where the PBMs come in. Now, they will tell you, well, we're taking that money and we're giving it back to the companies, to the insurance. Well, if they are, and they're not keeping any of it, then why are their profits going up so much? Why are their profits going up over 600%? It's because they're keeping it. They're keeping it, and they're adding no value whatsoever to the system. Now, they will argue the fact. They will say, well, we're keeping drug prices down. Oh, yeah? How's that working out for you? It ain't working out very well at all, because drug prices are going up. I mentioned the competition, the fact that we got 3 companies that control over 80% of the market. That decreases choices. One of the things, and we talk about community pharmacy, and I know that's what Representative Collins is really wanting to focus on here tonight, and it's so very important, because, folks, we have to have community pharmacies. They are vital to the healthcare system. In many areas, the most accessible healthcare professional is the pharmacist, particularly in rural areas. As they go and as they are eliminated, we are losing a vital part of the healthcare system. But PBMs are shutting out a lot of these community pharmacies. I can tell you, I alluded earlier to the fact that I have served grandparents and parents and grandchildren and build up those relationships. One of the toughest things that I've ever faced is for a family member to come in to me literally in tears and say, I've got to change pharmacies. And I say, why? Because my insurance company, because my PBM, they say that I have to get it from them through mail order. Well, why won't you have to get it through them through mail order? Because they own the pharmacy. Representative Collins alluded earlier about vertical integration, and that's what we see. The PBM, they own the pharmacy that they're requiring the patient to go to. Well, guess what? That means they're padding their pocket even more. That's the kind of thing that we should be protected from. I'll give you a quick story. True story. Back when I was still practicing pharmacy and on my pharmacy, my wife, she had insurance through her employer. She had a different insurance plan than I had. She got her insurance and she got a prescription filled at my pharmacy. At my pharmacy. Now, this is the pharmacy benefit manager who owns the pharmacy. That night when I got home, I got a phone call from the insurance company saying that, well, your wife got a prescription filled here at this pharmacy, but if she gets it filled at our pharmacy, we can give her a lower copay. We can give her a discount. Now, supposedly there's a firewall in between the PBM and the pharmacy. Well, guess what? There wasn't that firewall there that night, not when I got that phone call. Can you imagine? And what's that doing? That's taking patients away from the community pharmacists. That's unfair business practices. So that's what we talk about. And ultimately, who suffers? Now, I don't want to give the impression I'm just here to try to make sure that community pharmacies stay profitable and make sure that they stay in business, although it is important, because if they don't stay in business, who's going to suffer? It's going to be the patient. It's going to be the healthcare system. Folks, the only thing that's going to bring down cost in our healthcare system is more competition, is free market principles. That's what we're trying to do now in Congress through the repeal and the replacement of the Affordable Care Act. We understand that we've got to get free market principles back into the healthcare system. We got to get competition in order to drive costs down in healthcare costs. We understand that. This is a problem, a big problem. Now, very quickly, I want to talk about 3 bills that are being proposed. First of all, I want to talk about Representative Collins' MAC transparency bill. Transparency. That means to give us the opportunity to see exactly what's going on. And you mention transparency to a PBM, and they go berserk. Oh my gosh, no, we can't have that. We can't have transparency. But Representative Collins' bill, the MAC transparency bill, which I'm proud to be an original co-sponsor on, it brings about greater transparency in the generic drug pricing. in drug pricing in general, but particularly in generic drug pricing. Many of the recipients of generic drug prices don't understand the cost structure. They don't understand how that works, where the additional fees are originating from, which is often a direct result of the fees that are leveraged by the PBMs, the prescription drug plan sponsors. Congressman Collins' bill addresses this issue and addresses more. Under his legislation, a process would be established to help mediate disputes in drug pricing. It would establish new criteria for PBMs to adhere to when managing the cost of prescription drug coverage. This MAC transparency bill is a step forward, not only for the industry, but for the beneficiary. And that's what's so very, very important. It's no surprise that costs are going up. No surprise at all. With the lack of transparency, that's what's going to happen. We've got to have greater transparency in the drug pricing system. And yes, that includes pharmacy. Yes, it includes the pharmaceutical manufacturer, but mostly it's got to be with the PBMs. If we have a CEO of a medication, of a pharmaceutical company like Mylan, like we had, come up and testify before us here in Congress, and I ask her about that gap there and where that money's going. She doesn't know, and I don't know. There's a problem. That means we need more transparency. And that's exactly what happened. Now I want to talk about another problem. It's called DIR fees, direct and indirect remuneration. Let me tell you, this will be the death of community pharmacy. DIR fees are what they refer to as clawback fees. What happens is when you go into a pharmacy, you get a prescription filled, the pharmacy's computer calls the insurance company's computer, the PBM's computer. It tells us how much to charge the patient in a copay and tells us how much we're going to get paid. However, with these DIR fees, months later, after we've already been promised how much we're going to be paid, pharmacists are getting bills from these PBMs that are saying, well, we didn't make quite as much that quarter as we should have, so we're going to have to take back this. We're going to have to claw back this much. I met with pharmacists from the New York State Pharmacy Association, and they were telling me literally horror stories about getting bills for $85,000, $110,000 in clawback fees. Folks, that is not a sustainable business model. When you're trying to run a business, a community pharmacy, and you get a bill months later in the hundreds of thousands of dollars, that is not sustainable. You can't stay in business that way. We have got to do something about DIR fees, and thankfully, Representative Morgan Griffith from Virginia has a bill addressing this, and I'm supporting him on that bill. In fact, in a recent survey, nearly 70% of community pharmacists indicated that they don't receive any information about when those fees will be collected or how large they'll be. And again, ultimately, who ends up being penalized? Who ends up being penalized? The patient. The patient ends up being penalized. And folks, understand, this is not a partisan issue. These PBMs, they don't care whether you're Republican or Democrat. They care about one thing, and that's profit. That's all. Now let's talk about one other. Let's talk about a bill that Representative Brett Guthrie from Kentucky has, H.R. 592, the Pharmacy and Medically Underserved Areas Enhancement Act. Folks, under this bill, many of the individuals who seek consultation, especially seniors, can continue to receive that quality input and expertise. This bill is known as the pharmacy provider status. And simply what this will do will be to make sure that the pharmacists who are giving consultation, that they're being reimbursed for that. That's vitally important. Pharmacies are at the front line in healthcare. There's so many diseases. The pharmacists who are graduating today are so clinically superior to when I graduated. Their expertise is beyond anything that I ever imagined it would be. And we need to make sure that we're utilizing that. That's going to be a key in helping us control healthcare costs, is utilizing all these allied health fields and making sure that we are using them to their fullest potential. And this bill will help us to do that. So there are just a couple of bills, or 3 bills, that are being introduced right now with community pharmacists that impact pharmacy, but more importantly, that impact healthcare, and that are going to help us to have a great healthcare system and to continue to have a great healthcare system. There are a couple other things that I wanted to mention. I'm going to hold off on those because, again, I want to make sure that everybody understands the point that I'm trying to make, and that is just how important, how vital the community pharmacies are, and just how bad the PBMs are, and how they're ripping off the public. They are ripping off the public. Look at their balance sheets. Look at the profits. Again, they will want to argue and they will want to say, we're holding down drug prices. Again, how's that working for you? And it's not working. It's not working because they are pocketing the profits. If they were truly doing what they say they're set out to do, we wouldn't see this escalating drug prices like we're seeing. Yes, there are some bad actors out there, as there are in every profession. Yeah, we had Turing Pharmaceuticals and Martin Scarelli and the Pharma Bro, and that was just an outright, I mean, this guy was a crook, no question about it. We had Valiant Pharmaceuticals and what they did with Isoprel and Nitropress. That's true. We just here recently, Marathon Pharmaceuticals bought a drug from that was available over in Europe, brought it over here and got it approved in America. Now they're trying to, a very important drug for muscular dystrophy. Now they want to increase the price to an enormous amount that won't be affordable for patients. Those are bad actors. And you're going, as my daddy used to say, you're going to have that. You're going to have that. And we understand that. And those companies and those people, and we have with Valiant and with Turing and Marathon, we're calling them out too. They need to be called out. But we also need to focus on what one of the biggest problems is in escalating prescription drug prices, and that is the PBMs. They bring no value whatsoever to the system. They put none of their profits back in the research and development. Community pharmacists play an important role in our healthcare system. I'm proud to support our community pharmacists. I'm proud to have been able to practice in a profession for over 30 years, a profession that I know brings a great deal of value to patients and to their families. Again, I want to thank Representative Collins, and I want to commend him for his hard work. Representative Alston Scott is here also. He's been a champion of this as well. They understand, they get it, and I appreciate their efforts on that. And I appreciate everyone who has been here tonight. Thank you for hosting this here tonight, Representative Collins. I appreciate your support, and I yield back.
Thank you. And before you get going, I want to tell you, you told the story about getting a call from your own pharmacist. I was here, you and I were together about, I think it was sometime last year, 6 months ago. We're doing this and talking about this issue of mail order. We're talking about this. I had a member who was watching us on the floor talk about pharmacy and talk about the PBM problem and got a call from the PBM because they had gotten a prescription for their child. Yes, the day before, they're getting a call in their office from the PBM saying, you know, if you just switch it from your local pharmacist, we'll do it better. That's why we're sitting here. Interesting thing you brought up on DIR fees. I want to say this because you said we have a right here that sort of describes what you were talking about, and I'll put it right here that people can see it. But there's an interesting part of this DIR fee issue. It forces Medicare Part D beneficiaries to pay inflated prices for point of sale that are higher in actual cost of the drug, and this will cause the cost of the drug will be recouped in DIR fees, which are retroactively assessed later. Many beneficiaries are moving past their Part D benefit faster and hitting the donut hole sooner, forcing them to pay out-of-pocket costs. This is particularly true with those with life-saving or specialty drugs. These are things that we're seeing. According to the community, patients will be forced to pay out-of-pocket, might be forced to cut back or abandon their treatment. According to the Community Oncology Alliance, pharmacists lose $58,000 per practice on average to DIR fees each year. This makes it difficult for independent community pharmacists to keep up. When patients pass through the donut hole into catastrophic coverage, guess who picks up? CMS takes on the cost-sharing burden. This is why this matters in Congress. This is why we're going to look at this. These costs have increased from $10 billion in 2010 to $33 billion in 2015. This is just dealing with this issue. CMS, we've got to have greater transparency on this. This is why Morgan Griffith's bill is good, and we're going to continue to fight about this. And again, yet to have a PBM tell me I'm wrong here. And I know from your experience, you're seeing it as true as well. Thank you so much. With that, our other friend from South Georgia who's been outspoken on this, Austin Scott, comes to the floor to talk about his experiences with this as well.
You know, Mr. Collins, I had several parents in my office today, and I thought I'd talk about a couple of the meetings that I had. And had a father there talking about his son Gabe. He had a T-shirt on with H4G, stands for Hope for Gabe. And I listened to him talk about his son and the life-threatening disease that his son has and the threat that his son is under. The threat that his son is under because of a U.S. pharmaceutical manufacturer named Marathon. I'd like to read part of an email that I have from him. Just hope you're well. Just want to let you know that my son Gabe takes a drug called Delflazicort. He has since he was 5 years old. He was now 11. We currently pay $116 for a 3-month supply of a 15 milligram dose for Delflazicort. We're getting this drug from Europe as it was not available here in the United States and have had no access with problems to date. Now, many of you heard about this story. The FDA approved the same drug for sale in the United States. What did the drug manufacturer do with the price of it? Well, Marathon took the price from $116 a quarter to approximately $87,000 a year. Now, this is what's happening. Drugs that are available everywhere else in the world, it's not that they're being developed with extensive research and expensive research in our country. People are simply buying the right to sell the drug in the United States. And as soon as approved and available in the U.S. marketplace, it's no longer legal for people to import that drug from Europe. Marathon priced the drug at $89,000 per year. Reading again from his email in bold letters, the same drug we are getting today from Europe for $450 per year with an exclamation point, the exact same drug. We need your help here. The dosing community needs your help, and specifically Gabe needs your help. As I sit here and look at the American flag, you know there is no other country in the world that allows their citizens to be treated like this. None. And I'm embarrassed that this Congress hasn't done anything about this abuse of the to the American citizens from the pharmaceutical and the PBM industry. I know our president, and I'm glad that we have a president with the courage and the boldness that our president has had the executives to the White House. I would suggest that a good meeting also would be to have the parents, have the father of Gabe, have the mother of Gabe come to the White House. Sit down in the same room with the TVs on with the executives from those companies that are cheating these people. Let's let the executives explain on TV in front of the parents, in front of the child who needs that life-saving drug, why it costs $450 in another country but should cost $87,000 in America. Another group of parents that was in my office today was there representing juvenile diabetes. Well, I'll tell you, I had a heart-wrenching discussion with a mother in my office in Warner Robins about her daughter, insulin dependent. She's got to have it or she dies. This mother had a job actually in another country and talked about what she paid in another country to receive that drug, the same drug, insulin, for her child. A fraction of what it cost in America. I think it would be great for our president to have that mother and that daughter, or the mother that was in my office today talking about her daughter, come and sit down at the White House, and maybe the president of Eli Lilly could come and sit down, and maybe we could put the TV on, the cameras on, so everybody in America could see the CEO explain why insulin, which has been around for decades, costs as much in this country as it does when it doesn't cost anywhere near that in any other country. Something's got to give. Something's got to give, and the American families have given enough. So I'm hopeful that we'll move sooner rather than later. American families can't take it anymore. A drug that costs $450 that can be imported from Europe shouldn't cost $87,000 in America. On top of the issues with what's happening with the manufacturers, we've got the issue with the PBMs. Why shouldn't you know what the PBMs are getting in a kickback? Everywhere else you go, you get a price sticker. You know what the rebates are when you go to your local car dealer. They're readily advertised. Why shouldn't you know as the American citizen? My friend Mr. Collins and I have been working on it for years. We worked on it back in the state legislature, and in fact, we passed a bill back in, I think it was 1987 was the first Transparency Act that we passed in the state legislature in Georgia. And I hope that governors and members of the state legislatures will go back and address this issue as well. It can be done at the state level. The transparency issues can. That bill came to the House floor, and it passed 150 to nothing. Not a single Democrat, not a single Republican voted against that bill. Every single member that was there that day voted for the bill. Mr. Chairman, we know something's got to be done. I just hope that we take action sooner rather than later. And I would just like to make one last request. Mr. President, I hope you'll invite these parents and their children to the White House. I hope you'll invite the CEOs of these companies to come and sit down at the same table. And I hope you'll even invite the press to come and publicize the meeting. With that, Mr. Collins, I'd like to yield the remainder of the time and say thank you so much for standing up for the American citizens. I'm honored to be a friend of yours, and thank you for allowing me to be in the fight.
Well, Representative Scott, you bring out this issue, you bring it out with passion. This is exactly what we need to have as we go forward in this discussion. This is exactly what the PBMs don't want to have. They don't want to have transparency. They don't want to talk about it because we've been talking about it now for years on this floor, and it just continues to get worse. In fact, the Prescription Drug Price Transparency Act that we're getting ready to introduce, and you're a part of, and others, just the other day, they're already trying to undercut this bill. I recently saw an interview with Mark Merritt. He's the CEO of PCMA, the trade group for PBMs. The article misrepresented PBM's role in the marketplace. Now, that's a shocker, really. Distorting the facts to protect PBM's ability to continue profiting at the expense of beneficiaries and taxpayers. So tonight, let's have a little fact check. Let's look at this. The claims by Mr. Merritt versus the truth. First, Mr. Merritt claimed that PBMs play an important role in negotiating price discounts in order to pass those savings along to customers. In fact, what he said was, we have an interest in lower price and bigger discounts, and we're going to negotiate the most aggressive discounts we can. Well, it is true that PBMs do effectively negotiate huge discounts. However, the patients never see this discount. Rebates reflected in their prices or out-of-pocket cost. These rebates and discounts merely pad PBM's profit margins. They do not increase patients' well-being. This lack of transparency allows PBMs to receive massive rebates and refuse to pass those savings along to consumers or customers. In fact, what is interesting, there is proof that transparency in MAC pricing saves more money than the PBMs are willing to admit. You want an example? Let's look to Texas. Texas has one of the oldest MAC-style laws. Texas passed MAC transparency legislation similar to the Prescription Drug Price Transparency Act in 2013 of June. Now, here we go. Mark, explain this one. Since Texas passed their law, their Medicaid fee-for-service prescription drug expenditures for the top 100 drugs fell from $219.54 per prescription to $91.32. Yep, you're doing a good job negotiating for your bottom line. What else does he say? Number 2. Merritt tries to distort the purposes of the Prescription Drug Transparency Act by drawing concerns to transparency in the drug marketplace. Let's see what he says. He says, the kind of transparency to be concerned about is where competing drug companies and competing drugstores can see the detailed arrangements that we have with all of their competitors. Well, seeing how they own part of the competitors, not really a lot of things going on there. Our legislation simply would not allow competing drug companies to see detailed arrangements that PBMs have with competitors. Mark, quit lying. This statement is a misrepresentation of what Prescription Drug Transparency Act does. Competing pharmacies would not be able to see the arrangements their opponents have with PBMs because they would not be publicly disclosed. Transparency measures and contractual agreements include confidentiality clauses preventing public disclosures. May I remind Mark, he has gag orders in some states where the pharmacists can't even talk about these issues. And by the way, they send letters to pharmacists saying, oh, don't go talk to your elected officials because if you do, we'll cut your contract off. Wow, that's concern, Mark. Furthermore, the disclosure of sources of drug pricing determination remains confidential and is only disclosed to pharmacies and their contracting entities. PBMs distort transparency to mean only public transparency in an attempt to protect profitability that comes with keeping their corrupt business practices in the dark. I wish he'd have stopped there. He didn't. Let's go on. The third, Mark Merritt says, we want to make sure that wholesalers who sell to the drugstores aren't trying to sell the most expensive thing and pass cost on to consumers. All right, here we go again. This is getting familiar. It has little to do with wholesalers. PBMs designed the formularies. Yes, we understand this, Mark. Formularies that dictate what drugs are covered by insurance. Because there's no transparency, PBMs are able to receive drugs at discounted prices but refuse to tell employers. PBMs are then able to still charge employers full amount of the drug even though they're receiving it cheaper. PBMs often receive large rebates to incentivize them to include expensive name brand drugs on their formularies even though cheaper generics are available. Listen, Mr. Speaker, listen. They receive large rebates to incentivize them to include the expensive brand name drugs on their formularies. I had an issue just like that with my own mother just recently when she needed medication. She'd been on it for 8 months. They had to reauthorize it after the first of the year. And I said, well, is there another issue that she could have? They said, well, this is the only one on the formulary. PBMs don't control pricing. PBMs don't control what drugs come to the market. Another falsehood. PBMs substitute expensive drugs and overcharge Medicare Part D, TRICARE, and FHB programs. This means they're lining their pockets with the money from the taxpayers. Fourth thing, if drugstores like those terms, they can sign a contract, and if they don't like them, they can join some other plan. Oh, I love this. This is classic, Mr. Speaker. PBMs hold the disproportionate share. I've already talked about 3 of the largest PBMs own 80% of the market. 80%. Because PBMs have stranglehold on the market, community pharmacists cannot stay in business without being forced to contract with them. It forces community pharmacists to sign take-it-or-leave-it contracts with anti-competitive and unfair provisions and from transmitting it with a written consent. These are just crazy. I mean, I had one of my pharmacists who was on their plan, actually had a letter sent to their customers who said, you're no longer on the plan. He called the PBM. The PBM says, no, you're still on the plan. He said, then why did you send a letter out? I said, oops, must have been a mistake. He said, well, why don't you send a letter out telling them that they're wrong? They said, oh, we don't do that. That's on you. Yeah, because all you want to do is keep the money. Follow the money, Mark. It's easy. I understand running a trade association is tough, but at least be honest about it. The last thing, community pharmacists typically are paid more by plans because there is not as much competition. Well, 5 for 5. Community pharmacists in Northeast Georgia and across the United States are under constant threat of going out of business because of PBMs. PBMs exploit the market, prey upon community pharmacists using spread pricing and retroactive DIR fees. PBMs also use a disproportionate share of the market to steer patients to pharmacies they own themselves. The Prescription Drug and Transparency Act is vitally important to improving fairness and transparency in the healthcare system. Community pharmacists must be kept in business and patients should have the choice to receive care from their local pharmacists. Community pharmacists might be afraid to stand up to PBMs. Community pharmacists many times are basically scared into submission. I've stood on the floor of this house many times. My pharmacist can't speak, but I can. And I'll remind the PBMs one more time, you can't audit me. You can go audit for profit, which you do every day, You can go hit them, but you can't hit me. I will continue to be a voice for community pharmacists. These members are being a community pharmacist. Our numbers are rising every day, and the president himself has actually begun to look at those middlemen in those pricing. So tonight ends another night of telling truth when the truth needs to be told. And with that, Mr. Speaker, we end another time of standing up for the American people and the community pharmacists. And with that, I yield back.
The gentleman from Georgia yields back. Under the Speaker's announced policy of January 3rd, 2017, the gentlewoman from the state of Washington, Ms. Jayapal, is recognized for 60 minutes as a designee of the Minority Leader.